Integumentary system. The structure and function of the skin. There are three major layers of the skin. The epidermis is thin but tough and formed primarily of keratinocytes. It's made up of several layers that ensures continual renewal of the skin. This layer is replaced every 4 weeks. The dermis is made up of collagen, elastin, and reticulin. It contains hair follicles, sebaceous glands, sweat glands, blood vessels, lymphatic vessels, and nerves. Cells of the dermis include fibroblasts, mast cells, and macrophages. Hypodermis is the innermost layer of the skin that consists of the adipose tissue. The primary function of the skin is to provide environmental protection, and it serves as a barrier against microorganisms, UV radiation, and loss of body fluids. It regulates body temperature, it provides immune surveillance, and it is also part of the activation of vitamin D. The normals and abnormals of the skin. Normals include the skin color being the expected color for ethnicity, even color consistency, warm, dry, smooth skin texture, a skin trigger that is less than 3 seconds, and the skin should be intact. Abnormals include pale or cyanotic, uneven color consistency, cold or cold to the touch, diaphoretic or very dry, cracking skin, a rough skin texture, skin trigger that is greater than 3 seconds, lesions, rashes, raised bumps, peeling, or scaling skin. Lesions of the skins are categorized as primary or secondary. Primary lesions develop as a result of a disease process, and it includes macules, nodule, pustule, plaque, papule, vesicle, or bulla. Secondary skin lesions are characterized as a lesion that develops changes over time or due to scratching or infection, and that includes atrophy, erosion, fissure, scale, scar, or ulcer. Pressure ulcers are damage to the skin and underlying soft tissue, usually over a bony prominence. They are categorized by stages and based on the damage of the skin. Stage 1 is a non-blanchable erythema that is present, and the skin does not have any breaks or tears, and it may look red in people with a darker skin complexion, and it may appear a different color than the surrounding skin. Stage 2 is the skin breaks and wears down or forms an ulcer. At this stage, the wound has expanded into a deeper layer of the skin, and it can look like a scrape, blister, or shallow crater. And during the stage, some skin may be damaged, beyond repair, or die. Stage 3, the injury has extended through the skin into deep tissue and fat. Stage 4, the injury extends to muscle, tendon, or goes as far as the bone. If a pressure ulcer is unstageable, that means that they are unable to determine the stage that the injury is at. The doctor cannot see the base of the wound to determine the stage. The base of the wound is typically covered by a layer of dead tissue. Deep tissue pressure ulcer is the injury is persistent, non-blanched, deep red, maroon, or has purple discoloration. The skin of the site remains intact, and it might be difficult to discern deep tissue pressure ulcer in darkly pigmented skin. Labs, diagnostics, and incident rate. According to the Agency of the Healthcare Research and Quality, more than 2.5 million people in the United States develop pressure ulcers. Labs include the CBC to evaluate the white blood count for signs of infection. An ESR would suggest osteomyelitis. They also test for nutritional parameters, which include albumin, prealbumin, transferrin, and serum protein. Adequate nutrition would provide adequate wound healing, promotes adequate wound healing, and blood cultures can be tested for signs of possible bacteremia or sepsis.
Infections of the skin. There are bacterial, viral, and fungal infections. The most common type is due to Staphylococcus or Streptococcus bacteria. The types of bacterial infection include folliculitis, which is infections of the hair follicles, furuncles, which is caused by abscesses of the hair follicles, carbuncles, which are collections of the furuncles, cellulitis, which is the infection of the dermis and subcutaneous tissue, and erysipelas, which is an acute superficial infection of the upper dermis. So on the left upper hand photo, I have an example of Lyme's disease, which is also a parasitic infection, and this is caused by the Borrelia burgdorferi bacteria that's found in ticks. In viral infections, these are caused by herpes simplex viruses. There's type 1 and type 2, and these are transmitted through the saliva. Another example is chickenpox and shingles, and this is caused by the varicella and herpes zoster virus. They're actually the same virus, but this shingles is the adult/dormant version of chickenpox. So on the upper right-hand photo, this is a photo of a child that has chickenpox. Another example is warts, and these are benign lesions that are caused by the human papilloma virus, or HPV. For fungal infections, those that are caused by dermatophytes, they are caused by superficial skin lesions, and fungal infections are also called mycosis. And tinea is for dermophytic mycosis. So for example, a tinea pedis is a fungal infection of the foot, also known as athlete's foot. Candidiasis is another example, and this is caused by the Candida albicans fungus, and these can infect the skin, GI tract, and the vagina. So on the bottom photo, this is an example of candidiasis, and you can see that it's present due to the white spots in the person's mouth. For labs and diagnostic studies, in bacterial infections, you would want to get a collection swab or transport medias, and these are done by getting cultural medias, which is like swabbing the skin or scraping the skin. And basically, you would want to see if the bacteria is aerobic or anaerobic, and this is done through gram staining. In fungal infections, it's very similar to bacterial infections. You would also use transport medias, and specifically for fungal infections, you could do a skin scrape of the scalp using a scalpel blade. And then for viral infections, you would do whole blood samples, and this could test for antibodies and antigens. A skin biopsy could be done, and specifically for rabies, fluorescent antibody testing. And skin cultures are done to determine which type of infection you have. For incidences and backgrounds, males are more susceptible to bacterial infections. Lyme's disease is more commonly found in Europe, and 60 to 70 cases of cellulitis is from men. Around 6.5 million incidences of invasive fungal infections cause 3.8 million deaths annually. So for this chart, I have a few examples of bacterial infections that are more prone in males or females. So for example, E. coli is more prominent in females, and Streptococcus pneumoniae is more common in males, just for some examples. The next chart is a viral infection incidences. So the darker bar shows the incidences and the lighter bar shows the prevalences. The bottom shows the age and the side shows is how the prevalences and incidences per 100,000 people. So as you can see, viral infections occur or affect younger people or children a lot more than they do for adults.
So for the stages of hair growth, we have 4 stages. There's 1 through 4. I'm going to be explaining the first one. So anagen phase, this is basically the growing phase. Hair grows in 0.5 inches per month, specifically on the scalp. And this lasts 2 to 7 years, depending on the person. For the body hair, there's much more shorter anagen phases. Moving on to the catagen phase, this is the transitional phase in between the anagen and the telogen phase. This phase lasts about 10 days, 1 to 2 weeks. And certain things can trigger the hair to be going into this phase and leaving the anagen phase early, which can be emotional stress, hormonal changes, nutritional deficiencies, medications, or underlying health conditions. This is just the transitional phase once again. Now moving into the telogen phase, this is the resting phase. This is a phase where all the hair halts growing and it stops for about 2 to 4 months, which is normal, right before going into the exogen phase. So the exogen phase is the shedding phase, and this phase is just a continuation of the telogen phase. So during the resting phase, hair is simultaneously growing. So as you can see in the photo, there's a little follicle growing while the top hair is shedding out, and this happens and this lasts about 2 to 4 months. So going into the abnormals. So in the anagen phase, there is a hormone called dihydrotestosterone, and that is created from the testosterone hormone. Too much DHT can lead to hair loss, specifically in men. Now going into the catagen phase, this is a transitional phase once again. Telogen effluvium is a rare case that affects catagen phase, telogen phase, and leading into the exogen phase. So the telogen effluvium is a rare case where this causes more hair to go into the telogen phase at an early transition, so more premature hair. A large amount of premature hair goes into the transitional phase, leading to telogen phase. Now moving into the telogen phase, this is where the hair stops growing more than the regular amount of time it's in there. So 2 to 4 months is normal for the telogen phase where hair is not growing, but due to telogen effluvium, this may cause prolonged telogen phase, which this can be related to certain things similar like stress, physical, mental health, poor vitamins, diet, etc. And in the exogen phase, due to the long delay of the hair moving into the telogen phase, there is a mass amount of hair going into the shedding phase all at once. So you can see about 300 hairs going in shedding. Okay, so for the types of alopecia, about 80% of men by 80 years, 80% of men who have some sort of hair loss by the time they're 80 years. And this happens in androgen alopecia. And the hair in the frontal temporal area, so the top of the scalp area, is replaced with a vellus hair, and this is the thinner hair, as you can see in the photo. It's very thin, short, small, due to the androgen-sensitive hair follicles on the top of the scalp. Sides and backs of the head and the scalp, there's more hair growing there, and it doesn't really fall out due to those areas not really being sensitive to the androgen, which plays a role in hair growth. And going into the female pattern alopecia, so this is more different than the male because in the females, their hair loss goes all over their hair. So it's not just in a certain area like the men have just on top of their head. It's more starts out center, then it starts to fade down their head basically. It's not as common as men, and it's could be due to genetic reasons, hormonal changes, increases with age, or after menopause, the DHT levels are altered, affecting the hair growth. And for alopecia areata, basically certain patches on the head, there's hair follicles that fall out easily due to the autoimmune T cell mediated or natural killer cell disrupting the natural hair cycle, leading to inflammation. And once again, stress, environment, genetics, metabolic disorders can cause alopecia areata. So moving on to the labs, for the incident rate, like I said, mentioned earlier, about 80% of men by the time that they're 80 experience some sort of hair loss. For women, it's less common, but race, African Americans have the highest rate of alopecia areata. It is less common in Asians compared with the whites. So for the labs, you can take a complete blood count and iron levels. These just check for anemia, and anemia could be a causing factor of hair loss. Thyroid function test, hormone levels, testosterone TSH, dihydrotestosterone, and scalp examination. Diagnostics, you can get a scalp biopsy, triggergram, and then the pool test is just testing the exogen phase. So it's testing the amount of shedding, how easy it is for the hair to be shed from your head when they pull.
For the structure and function of the nails, the nails are basically protective keratinized plates. So you have the proximal nail fold, the eponychium, which is your cuticle, the matrix, which is where the new nail grows from. Oh, and the cuticle also protects the tissue that grows new cells to build your nails. And then you have the nail bed, the nail plate, and the perinechium. Your nails grow at approximately 1 millimeter per day, and the function is to protect the tips of your fingers and toes, and it also provides support when you pick objects up, and you can use it to scratch, and it aids with sensation because there is counter pressure exerted onto the pulp of your fingertips by your nails. And then for normal findings, your nail plate should be clean. There are fine longitudinal ridges. It should be pink. The lunula, which is the little crescent shapes, should be white. Your nail folds should overlap the posterior and lateral borders, and your nail surfaces should be curved or flat. The posterior and lateral nail folds should be round and smooth. From the side profile, your nails should be at a 160-degree angle, and the thickness should be uniform. And there may be little white spots on your nails, but it's usually fine. It's just from minor trauma. Or darker skinned people can have brown markings, which is also fine. But if it's super dark, then it could be melanoma. And the cap refill should be less than 3 seconds. So for abnormal findings, paronychia is the acute or chronic infection of the cuticle. And this happens when there's constant, frequent exposure to moisture. So you can get this through sucking your thumbs, biting your nails, or excessive manicuring. So acute infection happens after a minor trauma, but chronic develops slowly over 6 weeks. And to treat it, you want to keep your hands dry or do warm soaks once in a while and take antibiotics or apply topical creams such as anti-inflammatories, antifungals, steroids, and calcineurin inhibitors. For onychomycosis, it's a fungal or dermatophyte infection of the nail plate, and it's caused by fungus, dermatophytes, yeast, or it could be a mix. And it's transmitted through direct contact. And the symptoms are discoloration, hyperkeratosis, which is like thickening of the outer layer of skin, splitting of the nail or nail plate destruction. And this is hard to treat with topicals because the ointments can't penetrate through the nails. So it's better to use systemic antifungals. Bowlines are just little grooves or depressions across your nails, and it usually happens because of acute illness or toxic reaction or local trauma, but they usually go away because they follow your nails as they grow. And then splinter hemorrhages are little red-brown linear streaks of damaged capillaries on your nail bed, and this happens from systemic diseases. And clubbing is when the inner edge of the nail elevates, so your nail angle is at 180 degrees or greater, and the distal phalanx looks round, wide, and shiny. And this usually happens with chronic lung inflammation, lung cancer, or heart defects, and it develops over time because of constant low blood levels of oxygen to your fingertips, but it could be reversed if you treat the underlying cause. And then habit tick dystrophy is when you have depressions or horizontal ridges down the middle of your nails, and this is because of continuous picking of the cuticle, which damages the nail base and the matrix. And this could be done consciously or unconsciously at the proximal nail fold, but if you stop, it should usually resolve itself. And then you can have pitting from psoriasis because it's an autoimmune condition. So you're losing the nail cells, which is why you can get little like pitting divots in it. And then for labs and diagnostics, you want to go to a dermatologist or a podiatrist to do a physical examination or a nail biopsy. So basically, they could either just take little clippings off your nail or do a biopsy of the nail plate or bed. The plate is less invasive, but the matrix is more invasive, and it could permanently alter the shape or structure of your nail. Or they could do a nail culture. So basically, they take clippings of your nail and then combine it with potassium hydroxide, and that will determine if you have a fungal infection or not. Or you could do a blood test to test for any deficiencies which would cause abnormalities in your nails. And here are our resources. And that is it. Thank you.